All right, so is everyone ready to get started on the other side?
Looks like we're all here.
Okay, perfect. Sorry about the delay. There was just someone else in this room right up until 12, so we just had access to it.
No worries.
All right. So we'll get started with today's journal club. So my name is Amanda. I'm a pharmacist that works in Sackville as well as the Moncton Hospital. I just included a few learning objectives just for your reference there. So we'll just get started with a patient case. So we have a 62-year-old female that has a past medical history significant for type 2 diabetes, which was diagnosed in 2006, and STEMI, hypertension, and glaucoma. Her current diabetes medications include metformin, 1,000 milligrams twice a day, gliclazide, MR 90 milligrams daily, and empagliflozin 10 milligrams daily. Her most recent A1C was 8.5%, and her calculated creatinine clearance is within normal limits. So just to start off, why is this topic important? So as you know, type 2 diabetes is a complex disorder that's characterized by hyperglycemia, and it is associated with a high risk of macro and microvascular complications. So it is well established that glycemic control is associated with a reduction in microvascular complications. However, the macrovascular benefits of glycemic control are less understood. In addition, concern has been raised regarding the cardiovascular safety of antihyperglycemic therapies, and subsequently, regulatory authorities have now mandated cardiovascular safety assessments of all new diabetes treatments. So just in terms of some previous literature that has investigated cardiovascular safety of antihyperglycemic therapies, there are a few trials which have demonstrated positive cardiovascular outcomes. So we'll just review a couple today. So you're likely familiar with the EMPA-REG trial. So the patient population consisted of about 7,000 patients with type 2 diabetes who were at least 18 years old with established cardiovascular disease. So at baseline, the mean age was 63. 71% of participants were male. The mean A1C was about 8.1%. 78% of the participants were already on antihyperglycemic therapy, and about 82% had had diabetes for more than 5 years. So the intervention comparator was empagliflozin 10 or 25 milligrams once a day or placebo, and that was added to existing therapy. And in terms of the outcome, at about 3 years, empagliflozin was associated with a 1.6% absolute risk reduction for the composite cardiovascular outcome, and that was death from cardiovascular causes, non-fatal MI, or non-fatal stroke. That result was driven by a significant decrease in cardiovascular mortality, as the non-fatal events were not significantly reduced, however. And it was also associated with a 2.6% absolute risk reduction for death from any cause, and a 1.4% absolute risk reduction for hospitalization for heart failure. And just of interest as well, the 10 milligram dose provided virtually the same benefit as the 25 milligram dose. The next one is the Canvas program. So this integrated findings from 2 different placebo-controlled trials. So the patient population in this study was about 10,000 patients with type 2 diabetes who were either at least 30 years old with symptomatic cardiovascular disease, or at least 50 years old with at least 2 cardiovascular risk factors. So at baseline, the mean age was about 63. About 64% of participants were male. The mean A1C was about 8.2%, and the mean duration of diabetes was 13 and a half years. So for the intervention and comparator, they had canagliflozin, which was either 100 or 300 milligrams once a day, or placebo, and both of those were in addition to standard of care. And for the outcome, at about 2.5 years, canagliflozin was associated with about a 0.45% absolute risk reduction for the composite cardiovascular outcome. So again, that was death from cardiovascular causes, non-fatal MI, or non-fatal stroke. However, when they looked at the individual components of the composite outcome, there was no statistical differences. And in addition, there was a significant decrease in the primary endpoint only in patients that had symptomatic cardiovascular disease. So those results are largely applicable to patients with type 2 diabetes that have established cardiovascular disease already. As you may have heard, it was also associated with an increase in fracture rates and a doubling in the risk of lower extremity amputation. So that risk was strongest in patients that had a prior amputation already. So with that in mind, you would want to avoid this medication in that particular population, just because the risks appear to outweigh the benefits. And I just wanted to mention as well, there also is a cardiovascular outcome trial for semaglutide, which is a new GLP-1 receptor agonist. And just the bottom line of that trial is that it did significantly decrease the primary composite cardiovascular outcome in patients with type 2 diabetes at high cardiovascular risk, where this result was primarily driven by a reduction in non-fatal stroke. Just to briefly review liraglutide, which is the focus of the LEADER trial. So it is a glucagon-like peptide-1 receptor agonist, which you might know as Victoza. So it is a subcutaneous injection that's dosed once a day. It works by activating the GLP-1 receptor agonists or receptors in pancreatic beta cells. So this will increase glucose-dependent insulin release, and it decreases glucagon secretion. It also slows gastric emptying and reduces appetite. It does have an A1C reduction of about 1%. Weight loss can range from 1.6 to 3 kilograms, and there is negligible hypoglycemia risk when it's used as monotherapy. Now just to move into the critical appraisal of the LEADER trial, which was published in 2016. So the objective of the study was to assess the long-term effects of liraglutide on cardiovascular outcomes and other clinically important events. So in terms of the trial design, it was a multi-center, double-blind, placebo-controlled trial that was performed at 410 sites in 32 countries. So patients were recruited and underwent randomization from September of 2010 through April of 2012. The trial did use a one-to-one randomization strategy, and they had a minimum follow-up of 3.5 years with a maximum follow-up of 5 years. So in terms of the research question PICO, so the population of interest consisted of patients with type 2 diabetes at high risk for cardiovascular disease. The intervention was liraglutide 1.8 milligrams sub-Q daily, with the comparator being placebo, and both of those were in addition to standard of care. And the main outcome measure was death from cardiovascular causes, non-fatal MI, or non-fatal stroke. We'll move into the methods. So the authors did perform a sample size calculation, and they determined that 8,754 patients would need to undergo randomization. So they had a total of 9,340 patients that underwent randomization, and that was pretty well evenly split between the study groups. In terms of baseline characteristics, there weren't any significant demographic or clinical differences between the study groups. And I just listed a few characteristics of relevance. So the mean age was about 64. About 64% of participants were male. The mean BMI was 32.5. Patients in the study did have a long-standing history of diabetes, so about 12.8 years. 88% of participants were already on anti-hyperglycemic therapy at baseline. The mean A1C was 8.7%, and you can see there the majority of patients did have established cardiovascular disease. So patients with type 2 diabetes who had an A1C of 7% or more were eligible if they either had not received drugs for this condition previously, or if they were treated with one or more oral antihyperglycemic agent, insulin, where they specified it was either NPH long-acting or a premix formulation, or a combination of the agents. And of that patient population, the patients had to be either at least 50 years old with at least one cardiovascular coexisting condition, or at least 60 years old with at least one cardiovascular risk factor, which are listed there for your reference. So as you can see there, they did have quite a few exclusion criteria, but some of the major ones were patients with type 1 diabetes, use of a GLP-1 receptor agonist, DPP-4 inhibitor, or rapid-acting insulin within 3 months prior to screening, having an acute coronary or cerebrovascular event within 14 days before screening, or if they had a family or personal history of multiple endocrine neoplasia type 2 or medullary thyroid carcinoma. So the trial did start with a 2-week placebo run-in phase just to establish whether patients were able to adhere to the injection regimen. And then patients were randomly assigned to receive either liraglutide or placebo in addition to standard of care. So patients were started on 0.6 milligrams of liraglutide, and the dose was subsequently increased at weekly intervals to 1.2 milligrams and then to 1.8 milligrams, which was the maximum, and that was based on patient tolerance. So for patients that didn't meet the recommended target for glycemic control during the trial, the addition or adjustment of any antihyperglycemic agent was permitted, but just not drugs that were part of the incretin pathway. And as I mentioned, the duration of the trial was 3.5 to 5 years of receiving the assigned regimen, and an additional 30 days of follow-up after that. So in terms of the outcome, so the primary composite endpoint was first occurrence of death from cardiovascular causes, non-fatal MI, or non-fatal stroke. They did have quite a selection of secondary endpoints as well, but a few just to mention would be that they looked at first occurrence of an expanded composite cardiovascular outcome. So that encompassed the primary outcome measures in addition to looking at coronary revascularization, hospitalization for unstable angina or heart failure. And then they also looked at each of the individual components of the outcome as well. They also looked at death from any cause and first occurrence of a composite microvascular outcome. So looking at the results now. So you can see there for each study group, about 97% of participants completed the study. The median follow-up was 3.8 years for each group. And just of relevance, the median daily dose of the liraglutide was 1.78 milligrams, meaning that most patients were receiving near maximum doses of the medication. In terms of the primary endpoint, so the primary composite endpoint occurred in fewer patients in the liraglutide group than in the placebo group, with a number needed to treat of 53. So that result did fulfill the statistical criteria for both non-inferiority and superiority. However, it was primarily driven by a reduction in cardiovascular death, as the other components of the composite endpoint were not statistically significant, which are just in the black boxes there. Moving into the secondary endpoints. So the rate of death from any cause was lower in the liraglutide group than in the placebo group, with a number needed to treat of 72. And as I mentioned, death from cardiovascular causes occurred in fewer patients in the liraglutide group than in the placebo group, and that had a number needed to treat of 77. And lastly there, the incidence of the composite outcome for renal or retinal microvascular events was lower in the liraglutide group than in the placebo group. However, that difference was driven mostly by a lower rate of nephropathy events in the liraglutide group, and that had a number needed to treat of 67. So in terms of adverse events, acute gallstone disease was more common with liraglutide than with placebo, and that did include severe events with a number needed to harm of 84. And adverse events that resulted in permanent discontinuation of the trial regimen were more common with liraglutide than with placebo, and that result appears to have been driven largely by gastrointestinal events in the liraglutide group, such as nausea, vomiting, and diarrhea. In terms of limitations, so the trial was funded in part by the manufacturer of liraglutide, which is Novo Nordisk. In addition, 4 out of 15 members of the steering committee were Novo Nordisk employees. That's just something to keep in mind. The patient population did consist of individuals who were at high risk for cardiovascular events and who had a baseline A1C of 7% or greater. So the observed benefits and risks may not apply to patients with lower cardiovascular risk. Patients in the trial were followed for only that 3.5 to 5 year duration. So you just want to keep in mind that the safety and efficacy data would only apply to that time frame. And lastly, subjects who completed or discontinued the trial without having an outcome were censored from the day of their last visit, and events occurring after that visit were not included. So that means that key events theoretically could have been missed. In terms of strengths, the trial did have the largest sample size of any GLP-1 receptor agonist study, and it did have the longest duration of all published cardiovascular outcome studies when it was released. It was a well-designed randomized controlled trial whereby it was properly randomized and blinded. It was appropriately powered, and all the cardiovascular outcomes were pre-specified as well as clinically relevant. As I mentioned, about 97% of participants did complete the trial, so that is a good study retention rate. They used an intention to treat population when they were doing the superiority analysis, so that's a strength. And then looking at safety and adverse events was certainly a good addition to the trial. So in terms of knowledge translation, so liraglutide is the first drug of its class to demonstrate positive cardiovascular outcomes in a randomized controlled trial. And while the trial did include some patients with cardiovascular risk factors only, over 80% of patients did have established cardiovascular disease, and only about 10% of the primary events occurred in patients that didn't have clinical disease. So the results of the study are most applicable to patients with type 2 diabetes and clinical cardiovascular disease that require additional therapy. And lastly, the results of this study, along with the other cardiovascular safety outcome studies, do help to provide guidance when selecting a second agent after metformin. So this is just the updated algorithm for managing hyperglycemia and type 2 diabetes, which comes from the 2018 Canadian Diabetes Clinical Practice Guidelines. So the guidelines do emphasize that based on the evidence to date, a GLP-1 receptor agonist or SGLT2 inhibitor that has demonstrated cardiovascular benefits should be considered as initial add-on therapy for patients with pre-existing type 2 diabetes and clinical cardiovascular disease who have not achieved target A1C on existing treatment in order to reduce their cardiovascular risk. You might notice here, this box here, it doesn't include semaglutide, but that's only because it received Health Canada approval after the guidelines were already in press. So just to bring it back to the patient case that was presented in the beginning. So just to summarize, 62-year-old female that has a past medical history of type 2 diabetes, diagnosed in 2006. She does have clinical cardiovascular disease, and she's not achieving her A1C target on her existing therapies. So is liraglutide something you might consider or recommend for this patient? Okay, so I'm hearing some yeses, so that's great. And then just something to keep in mind with liraglutide is the cost and if the patient has drug coverage, so something to investigate before making that recommendation for the patient. So, in conclusion, for patients with type 2 diabetes and high cardiovascular risk, the addition of liraglutide did reduce the risk of composite cardiovascular events and death from any cause as compared to standard of care. And again, just keeping in mind that that primary composite endpoint was driven by a significant decrease in cardiovascular mortality as the non-fatal events were not significantly reduced. If there's any questions, I'd be happy to give them a shot.
Know the cost? How much it costs?
I briefly looked that up, and I think it was around like $700 for a 100-day supply. That was something that I found. There's a really good RX file summary, so that was included in there, like something just to keep in mind. So it kind of estimated around $700 for 100 days.
But correct me if I'm wrong. You keep getting covered through like in the resident program, right? You keep getting covered as long as you met the criteria.
Sorry, I'm having a very hard time hearing that question.
The question, Amanda, was whether you could get it covered through MBPDP if the patient met the criteria.
Well, when I went on MBPDP last week, I didn't see it even listed. So I found that kind of interesting.
They're really hard. Yeah, as she'll go to cut special off. Yeah, that's why I didn't know this. I'm not sure without but yes, she'll just was just last week. I was just going to say that. Yeah. So.
Just in case you guys couldn't hear that at the other sites, the comment was that the SGLT2 inhibitors just last week, you can now go through special auth through MBPDP.
Yeah.
We don't think that's the case with the GLP-1 agonist.
Mm-hmm. Yeah, not when I just briefly tried to look to see if it was under special auth, because I thought that question might be asked, but no, I didn't see it listed, but yeah, the SGLT2s would be something that's listed with criteria. Any other remaining questions?
So you mentioned the other medications that have like CV benefits. Is there any, how am I trying to phrase this? Is there any reason why you would choose liraglutide over the SGLT2 inhibitors and the others?
So there was just a question here to ask, like what would make you maybe choose one over the other that has cardiovascular benefits? So definitely drug coverage. So like we just discussed, if the SGLT2s are covered with criteria, that might be something that you might try first if it's going to be covered under the patient's plan. You'd also want to consider patient preference. Maybe they don't want to do an injection therapy, so maybe they might want to try the SGLT2s first, and if it's still uncontrolled, then at least you have another option. And then definitely considering renal function might help you make a decision from one or another for sure.
In another pharmacy student when he was recently it was Dr. Hall and so they're the endocrinologist and the nephrologist here. And they basically said they go to an SGLT2 inhibitor if they have any sort of failure, whether it's heart failure or kidney failure, like albuminuria or whatever that they are looking at, and they usually only do GLP-1 if they don't have any sort of kidney issue. And that's kind of their gist of how they choose one or the other.
Yeah, that's a good point. I do remember that statement being made when they did the pharmacy grand rounds about the update on diabetes. So that's a good point. Thank you.
Thank you very much, Amanda. We're just a few minutes past 12:30, so if there's no other questions or comments, we will stop there. But thank you again for a really great presentation. So we have our next regional education event will be Grand Rounds on, I believe, March 26th. Denise Campo is speaking about biosimilar medications, so everybody is invited to that. And for those of you in attendance today, please just send me an email with how many people attended at your site or the attendance, and I'll send out evaluations this afternoon. Thanks, everyone.
Thank you.
Thanks.